Welcome to Pediatric Case Review. Today's lecture covers facial palsy in children, a concerning condition that requires prompt recognition and management. We'll discuss clinical presentations, examination techniques, pathophysiology, diagnostic approaches, and treatment options. Let's begin exploring this important pediatric condition. Let's begin with a case. A 7-year-old child presents with a 2-day history of inability to close the right eye and drooping of the right side of mouth. The symptoms appeared suddenly. What is the most likely diagnosis? A. Bell's palsy. B. Ramsay-Hunt syndrome. C. Facial nerve trauma. D. Congenital facial nerve palsy. The correct answer is A. Bell's palsy. This is the most common cause of acute facial palsy in children, characterized by sudden onset unilateral facial weakness. About 60% of cases are preceded by a viral prodrome. The clinical picture described, acute onset, unilateral involvement, and absence of other neurological findings, is classic for Bell's palsy. Which of the following is not typically seen in pediatric facial palsy? A. Difficulty closing eye on affected side. B. Bilateral facial weakness. C. Inability to wrinkle forehead. D. Drooling from corner of mouth. Consider the typical presentation patterns we see in children with facial nerve dysfunction. The correct answer is B. Bilateral facial weakness. Most cases of facial palsy in children, over 90%, are unilateral. Bilateral facial weakness is rare and should raise suspicion for systemic conditions such as Guillain-Barré syndrome, Lyme disease, or leukemia. The other symptoms listed are classic manifestations of unilateral facial nerve palsy. Here's our next case. A 5-year-old child presents with facial asymmetry, an erythema migrans rash, and a history of a tick bite 2 weeks ago. What is the most likely cause of the facial palsy in this case? A. Bell's palsy. B. Lyme disease. C. Otitis media. D. Congenital facial palsy. The correct answer is B. Lyme disease. 30 to 40% of pediatric Lyme disease cases develop facial nerve palsy. The classic triad of erythema migrans rash, tick exposure history, and facial palsy strongly suggests Lyme disease as the etiology. This is especially common in endemic areas during summer and fall months. All children with facial palsy in endemic regions should be tested for Lyme disease. When examining a child with facial palsy, which finding suggests a central rather than peripheral etiology? A. Inability to raise eyebrow. B. Preserved forehead movement. C. Incomplete eye closure. D. Drooping of corner of mouth. Think about the neuroanatomy of facial innervation and what distinguishes central from peripheral lesions. The correct answer is B. Preserved forehead movement. This is a key distinguishing feature of central versus peripheral facial palsy. In central lesions, forehead movement is preserved due to bilateral upper motor neuron innervation of the forehead muscles. Peripheral lesions, like Bell's palsy, affect all facial muscles including the forehead. This distinction is critical for determining the location of the lesion and guiding further investigations. Which examination should not be routinely performed in a child with acute facial palsy? A. Otoscopic examination. B. Skin examination for rashes. C. Lumbar puncture. D. Cranial nerve examination. Consider which evaluations are essential parts of the initial workup versus those that might be reserved for specific clinical scenarios. The correct answer is C. Lumbar puncture. This is not a routine examination for children with facial palsy unless there is clinical suspicion for meningitis or encephalitis. The standard evaluation should include otoscopic examination to identify middle ear disease, skin examination for rashes suggestive of Lyme disease, and a complete neurological examination focusing on all cranial nerves to detect any additional neurological deficits. A child with facial palsy can barely move the corner of the mouth with maximum effort. Based on the House-Brackman facial nerve grading system, which grade would this be classified as? A. Grade 2, mild dysfunction. B. Grade 3, moderate dysfunction. C. Grade 4, moderately severe dysfunction. D. Grade 5, severe dysfunction. The correct answer is D. Grade 5, severe dysfunction. The House-Brackman facial nerve grading system classifies facial nerve function from grade 1, normal, to grade 6, total paralysis. Grade 5 indicates severe dysfunction with only barely perceptible motion, as described in the case. This standardized scale is important for documenting severity at presentation and monitoring recovery over time. What is the primary pathophysiologic mechanism believed to be responsible for Bell's palsy? A. Bacterial infection of the facial nerve. B. Autoimmune demyelination. C. Viral-induced inflammation and edema. D. Congenital hypoplasia of the facial canal. Consider what we know about the underlying mechanisms of idiopathic facial palsy. The correct answer is C, viral-induced inflammation and edema. The leading theory suggests that Bell's palsy results from herpes simplex virus type 1 reactivation, causing inflammation of the facial nerve. This inflammation leads to swelling within the narrow facial canal, resulting in nerve compression. The compressed nerve experiences ischemia, leading to demyelination and nerve dysfunction. Other viruses implicated include varicella-zoster virus and Epstein-Barr virus. A 6-year-old presents with facial palsy during summer in an endemic Lyme disease region. What is the most appropriate first-line diagnostic test? A. Brain MRI. B. Lyme serology. C. Lumbar puncture. D. Electromyography. Consider the clinical context and the most efficient initial diagnostic approach. The correct answer is B. Lyme serology. For children presenting with facial palsy in Lyme endemic regions, especially during summer months, Lyme disease testing should be performed as a first-line investigation. This typically involves ELISA testing followed by Western blot confirmation if positive. Studies show that 10 to 25% of pediatric facial palsy cases in endemic areas are due to Lyme disease. Most uncomplicated cases of facial palsy do not require neuroimaging at initial presentation. Which finding is an indication for urgent MRI in a child with facial palsy? A. Complete unilateral facial paralysis. B. Additional cranial nerve deficits. C. No improvement after 2 weeks. D. History of recent upper respiratory infection. Consider which clinical features might suggest a more concerning underlying etiology requiring immediate imaging. The correct answer is B. Additional cranial nerve deficits. The presence of deficits in other cranial nerves besides the facial nerve suggests a central or brainstem pathology that requires urgent imaging. Other indications for neuroimaging include recurrent facial palsy, slowly progressive course, history of trauma, or signs of infection like mastoiditis. Standard Bell's palsy with isolated facial nerve involvement typically does not require immediate imaging. A 10-year-old presents with Bell's palsy that began 36 hours ago. What is the most appropriate initial treatment? A. Observation only. B. Oral prednisolone. C. Acyclovir. D. Surgical decompression. Consider the current evidence-based recommendations for managing pediatric facial palsy. The correct answer is B. Oral prednisolone. Current evidence supports starting corticosteroids within 72 hours of symptom onset. The recommended dose is 1 mg per kilogram per day, maximum 60 mg, for 7 to 10 days. Studies show that early steroid treatment improves recovery rate and reduces long-term sequelae. Antiviral therapy like acyclovir has less supporting evidence in children, but may be considered in severe cases or when herpes infection is suspected. What is the best approach for eye protection in a child with incomplete eye closure due to facial palsy? A. Patching the eye at night only. B. Lubricating eye drops during day, ointment, and tape at night. C. Surgical tarsorrhaphy. D. No specific eye protection needed. Consider the risks of corneal exposure and the most appropriate protective measures. The correct answer is B. Lubricating eye drops during the day, ointment, and tape at night. Proper eye care is crucial to prevent corneal abrasion, ulceration, and potential vision loss. Children should use artificial tears every 2 to 4 hours during the day to maintain corneal moisture. At night, lubricating ointment should be applied and the eye taped closed or patched to protect the cornea during sleep. Surgical procedures are rarely needed and reserved for prolonged cases. What is the appropriate antibiotic regimen for Lyme disease-associated facial palsy in a 12-year-old? A. Amoxicillin for 14 to 21 days. B. Single-dose azithromycin. C. Intravenous ceftriaxone for 14 days. D. Doxycycline for 3 days. Consider the recommended treatment guidelines for Lyme disease in the pediatric population. The correct answer is A. Amoxicillin for 14 to 21 days. For children younger than 8 years, amoxicillin at 50 mg per kilogram per day divided 3 times daily is recommended. For children 8 years and older, doxycycline at 4 mg per kilogram per day, maximum 100 mg twice daily, is preferred. Intravenous antibiotics are rarely needed unless there is central nervous system involvement. Single-dose regimens are insufficient for treating Lyme disease. Which of the following is not a common complication of pediatric facial palsy? A. Synkinesis. B. Psychological distress. C. Permanent hearing loss. D. Incomplete recovery. Consider the typical long-term outcomes and sequelae that children with facial palsy might experience. The correct answer is C. Permanent hearing loss. Facial palsy rarely affects hearing because the auditory nerve, cranial nerve 8, is separate from the facial nerve. Common complications include synkinesis, occurring in 15 to 20% of cases, which involves inappropriate co-contraction of muscles during voluntary movements. Psychological distress and social challenges are significant, especially in school-age children. Incomplete recovery occurs in approximately 15 to 30% of pediatric cases. What is the best predictor of favorable prognosis in pediatric facial palsy? A. Early treatment with steroids. B. Complete paralysis at onset. C. Signs of recovery within 3 weeks. D. Age under 5 years. Consider which clinical factors are most strongly associated with positive outcomes in children with facial palsy. The correct answer is C. Signs of recovery within 3 weeks. Early signs of improvement are strongly associated with complete recovery. Overall, 85 to 90% of children with facial palsy recover completely, which is a better prognosis than adults experience. Poor prognostic factors include complete paralysis at onset and absence of any recovery at 3 weeks. While early steroid treatment improves outcomes, it's not as strong a predictor as early spontaneous recovery signs. Thank you for joining us for this overview of facial palsy in children. Remember that most cases are Bell's palsy with excellent prognosis. Key clinical pearls include considering Lyme disease in endemic areas, prioritizing eye protection, and initiating early steroid treatment when appropriate. If you found this information helpful, please follow Pediatric Case Review for more educational content on pediatric conditions. Feel free to leave your questions or topic suggestions in the comments section below.